Good evening, ladies and gentlemen. As we are about to begin, we ask for your continued cooperation this evening and we wish you an enjoyable session. Please ensure that you are signed in with your first name and last name, for record purposes. You can right-click on your name where there will be an option to make any necessary changes. Lastly, we would like to inform you that this event is being recorded for storage and archives. Therefore, to ensure the integrity of our production, we kindly ask for your audio and video functions to be turned off. Thank you once again for joining us this afternoon and for your cooperation. It is now with great pleasure that I hand you over to our Vice President, Nalini Masir.
Good evening, ladies and gentlemen, and a special warm welcome to our specially invited guests and colleagues from the Mona and Cave Hill campuses. I am Nalini Masir, Vice President of the Pathology Club of UWI for this evening's event. I would like to thank you for joining us for what is to be the 20th installment of CPALMSI. As this time, and ladies and gentlemen, I am privileged to be introducing the speaker this evening, Dr. Rhonda Hutson, who will be sharing her wealth of experience and passion for medicine in a 45-minute overview of clinical forensic medicine. But before we begin, I will give you a brief background about Dr. Hutson. So Dr. Rhonda Lauren Hutson, who is a native of Georgetown, Guyana, received her Bachelor of Surgery and Medicine degree from the University of West Indies in 1996, and later the Master of Science in 2001. The Doctor of Medicine degree in Emergency Medicine was obtained in 2002. In 2009, she received a Master of Science in Sport Medicine. She is a certified sexual assault examiner, adult and pediatric, and an examiner trainer, having received training at the University of California, Riverside for adult and Nantecoke Hospital, Maryland for pediatric. She is currently employed as a consultant emergency physician at the University of the West Indies and associate lecturer at the University of the West Indies in Jamaica. Dr. Hutson has been directly involved in training healthcare practitioners in the management of sexual assault in Jamaica, Trinidad and Tobago, Grand Cayman, and more recently, St. Vincent and the Grenadines. Without a doubt, Dr. Rhonda Hutson is a motivating figure for us in the MBBS program, aspiring clinical forensic medicine, and most certainly in pathology. An inspiration to many, we are all honored, pleased, and privileged for her to be here with us this evening. And so, ladies and gentlemen, I ask where you are to welcome the very knowledgeable and most certainly the very passionate Dr. Rhonda Hutson.
Good evening. Sorry for that. I couldn't find the unmute button, but thank you so very much, Ms. Masir, and to the Pathology Club of the University of the West Indies. And I would like to congratulate you all. I've been hearing so many good things about you. And that was a very kind, lovely introduction. I hope I can live up to it. So you gave me it's kind of tall order. You said, just talk on clinical forensic medicine. So I had to figure out how it was I was going to position this topic. So let us begin by saying that I have nothing to declare. And what I'm hoping to do that by the end of this talk, that you will be able to define clinical medicine, briefly explore its scope, and to describe elements of a clinical forensic evaluation using emergency medicine as a substrate, to speak, because that is where I work for the most part. Now, a sort of very simple dictionary definition of forensic medicine says it's the application of medical knowledge to the investigation of crime, particularly in establishing the causes of injury or death. So that's kind of broad. And most persons, when you look at this topic, there's a distinction, it seems, between forensic science and forensic medicine, though most persons will say that forensic medicine really is sort of like a branch of forensic science, and forensic science being that overarching, that big tree. But essentially, if you want to look at a distinction, forensic science deals with the science of material and its analysis, okay, for legal purposes, and it would include things like serology and DNA and fingerprinting analysis and so on. So it essentially uses chemistry and physics and geology. Most of it, they would say, is a lot of chemistry and a little bit of biology. But forensic medicine uses medicine applied to the human body for legal purposes. So usually if you are practicing forensic medicine, you would have at some point gone through some formal training in medicine, either through nursing or through a medical degree. And persons, if you ask what exactly is forensic medicine, you'll see there are different types, and just about everything can be forensics, as long as this area of study and practice is related in some way to the courts. In other words, for purposes of what persons might say the administration of justice. Now, forensic pathology sometimes earlier on was actually sort of synonymous with forensic medicine, and it tends to be now relegated to when you think of forensic pathology, most persons will say it has a lot to do with the dead in sort of short order. But then you have other things there. And there's now even forensic emergency medicine. We'll go through a little bit of that as we go along. Now, this is a good read, The History of Forensic Medicine. And apart from tracing things all the way back to 2000 BC, parts of what it says is that really and truly modern forensic medicine actually began with an autopsy, right? When the body was dissected and prodded and so on, to help the courts decide on a particular matter. So for those of you who are interested to read on that, I think it's a good read. Okay. So forensic emergency medicine, because I'm kind of put this in here, really it's the application of forensic medical knowledge and appropriate techniques to the living patients in the emergency room. And that is something we knew from a while. This is what we went on. And it highlights something very, very key in a distinction between clinical forensic medicine and other types of forensic medicine. And essentially, it is that aspect of forensic medicine that deals with the living and gathering information for the use in a court or in any legal matters to arrive at some sort of conclusion or settlement, okay? Now, the scope of clinical forensic medicine is wide. And oftentimes, one of the things that I did when we're doing this, and I tell my residents, that sometimes we don't even realize as doctors that we are indeed practicing clinical forensic medicine simply because we don't label it as such. But if you look at the things that would come under clinical forensic medicine, we actually, a lot of us, especially those in the emergency room, do actually are forensic medical examiners. So anything that deals with injury, either arising from a criminal assault, domestic violence, physical or sexual abuse, elder abuse, we talk about that as a forensic matter, and any torture, of course. So that is pretty much if you're looking at the examination of the living victim. And then you have examination of suspected perpetrators, examination of self-inflicted injuries, medical investigation in traffic accidents, especially again in emergency room. We are called to see patients, either the drivers or the pedestrians or the passengers, and we are asked to make reports and so on, and help the courts to decide on legal matters. A fitness to drive, an examination for fitness to drive. Those of us who are practitioners will know oftentimes we get a request, sometimes from insurance companies or from the government, to verify that someone is actually fit to drive. And when we're doing that, we're practicing forensic medicine. An assessment of the effect of drink and/or drugs on a person's responsibilities, mental health assessment, right? Especially again for legal matters, like you have persons trying to claim somebody is not mentally capable of carrying out his or her own function. When we're asked to make such an assessment.
Yes, okay.
Sorry? Hello? Hello? Oh, there.
That someone just joined, so their mic was apparently on.
Okay, no problem. Okay, we'll continue. Right, so it also involves assessment of fitness to be detained and interrogated, assessment of physical ability for work. Doctors are asked to do that. Is this person able to work? That is forensic medicine. Medical care of detainees and the health care of police officers. That was particularly interesting. The healthcare of police officers is actually practicing forensic medicine. And of course, if you have determination of age. I think we know this a little bit more if we have to write reports and statements, right? Assessment of all different types of things. But importantly, I like to say this is sort of like the culmination of what we're doing. When after we've done our evaluation, we have to we put down our findings, we interpret those findings and prepare a document so that anyone who wants to use in the courts for legal matters can make a decision, or we help that process. And I like to say that is sort of the end result of our clinical evaluation. And then finally, when we present that information in a court as a witness in any capacity, we are really and truly practicing clinical forensic medicine. So a forensic evaluation then refers to the detection, documentation, collection and preservation of evidence, and interpretation of findings. So that's what we do. How we do this thing is by doing a forensic evaluation in there. So let us look at some, I'm going to make it a bit clinical. Let us look at some mistakes that or particular mistakes that could be made when we're not mindful of the fact that perhaps we are indeed in forensic medicine. So this was an ED case. A nurse removed a victim's head bandages that had been applied at the scene of a shooting. That is what we do. We remove people's clothing and all these wonderful things. But unknown to her, the bullet had dislodged from the patient's head into the bandages. She discarded the bandage, right? And although it was later discovered, the evidence was inadmissible because it could not be traced to the victim. Now, why did I put this here? Because what we're doing, remember, when we're practicing forensics, we are actually participating in legal matters, participating in criminal matters, participating in helping the court decide on these things. So we have to be aware that what we're doing, even when perhaps we are not thinking of the court, that something as simple as this and seemingly innocuous as this to the nurse had really a great effect on the legal outcome of this case. Similarly, it's a child, 5-year-old child was raped, sodomized. She's reviewed in the emergency department, but the doctor did not do a sexual assault examination kit, all right? And it was done later by the nurse, but the prosecution was not particularly happy because they thought that the evidence they had lost some evidence that perhaps was crucial. So again, we need to be mindful that, especially from emergency department perspective, that patients who come in with injuries may have other things that are particularly or equally important for us to pay attention to and to collect. This case, an intruder rapes and shoots a young woman. She sustains a life-threatening gunshot wound. She comes to the emergency surgery. She gets treated. But nobody, again, evaluated her for the sexual assault. So while the doctor apologizes at the court, the point is made that key information, especially DNA information, which perhaps could have truly connected the perpetrator to the crime, would have been lost. So the idea here is that I'm beginning to position forensic medicine and the work we do as forensic medicine, and that and as some of you here are students, are you thinking about it, even before you actually perhaps think of yourself as a forensic examiner, just perhaps working in an emergency room, these are things that you need to be mindful of. So why the need? Well, we know it, I think, from a sexual assault perspective, and this has been reported and documented extensively in the literature, right? So pretty much that the examination and finding of injuries and so on has an effect on the legal outcome of the case. So it's not just about, yes, we're examining a patient and we're documenting some injuries, we're collecting some DNA, but that actually makes a difference to the courts. So there is a definite need. And then, according to these researchers, as long as there are crime and violence related injuries, regardless of the nature, it doesn't have to be sexual, there will be a need for the forensic evaluation of patients. In other words, practice of clinical forensic medicine. And emergency physicians, we are beginning to grasp this, that we have to learn to incorporate forensic acumen into the comprehensive acute care that we deliver, right? And really and truly, it is within the scope of emergency medicine. And I'd like to say it's perhaps in the scope of any person who has training in medicine. It is within the scope. But is training useful? A quick answer would be yes. But here, this is important. So a 20-year-old male who had a gunshot to his left shoulder said he was shot from 30 feet by a known assailant and implored police to apprehend the man. The doctor, though, who was trained in forensic medicine, noted soot around the anterior wound and on the patient's clothing, and concluded in his mind that perhaps the story is not quite fitting the examination findings. And therefore, he reported that to the police. And in fact, what actually happened is that the patient actually shot himself and was trying to make a case that it was someone else who had shot him. Now, how many of us I don't know how many of you here are physicians, but how many of us would really think about that? And unless we are so trained, we may very well have caused someone to be wrongfully accused, and we might have participated or facilitated that accusation because of lack of training in saying that, this is not keeping with what you're telling me, okay? And again, of course, if you look in matters relating to sexual assault, the Department of Justice in the United States pretty much has standards by which even persons who are forensically untrained may be held. So the point is, there are standards that say this is what you should do forensically. And the point is, you can't really say you don't know, because you will be held to that standard. So there's a need for us, and it's a good thing that we're talking about clinical forensic medicine here. So it is a need for us to understand that even what we do in everyday, so to speak, practice may very well qualify for that, and we will be held to those standards because they exist. So the American College of Emergency Physicians essentially grasped that, and for some time now has actually have a program where residents are trained specifically in sexual assault in emergency department. And there is, in fact, forensic medicine as a subspecialty in emergency medicine. And this is something that is incorporated now in the residency programs. So it is important, it has a place. So which person in the emergency department requires forensic evaluation? Now, if you remembered some of that list I put up, the answer will be just about everybody, really. Stabbings, gunshot wounds, abuse of any sort, sexual or non-sexual, motor vehicle, all sorts of things that could come into emergency department. Really and truly, we know they will end up in some court, somebody suing someone, or even it becomes a criminal matter where the state will ask us to assist. So we actually need to be mindful of this, that we are indeed expected to have sound clinical forensic medicine principles in our armamentarium. We are suited, and I did say we're talking using emergency medicine as a substrate for our discussion. We're the first to evaluate a survivor of violence. Much of the evidence is available at the time of the visit. And this is important because, the forensic persons here will know that sometimes there's evidence you call trace evidence that is here today and gone I wouldn't even say tomorrow, is gone in a flash. And when we have them, we are best suited to collect all of that evidence as the patient is in front of us, right? Even in the absence of people like Dr. Alfredo, who is a trained forensic pathologist. We recognize all patients of violence as crime scenes, and that's important, right? All patients of violence are crime scenes. The evidence is short-lived, as I spoke to earlier. And you know what? Certainly in Jamaica, any doctor, so whether you work in the emergency room or not, you are actually considered an expert witness in Jamaica, for example, because just by virtue of your having a medical degree. So there are some other forensic mistakes that can be made by us, though. We destroy and throw away evidence. We have illegible records, partial documentation, or incomplete medical record. That is a forensic mistake, absolutely, because if our records cannot be read, they're incomplete, it means we are actually hindering the process of justice. Delay forensic examination, for whatever reason, it means we are likely to lose information. Okay, missing subtle injuries because of lack of pattern recognition. This is perhaps a lot of times, we see it a lot in child abuse cases. We're missing things because we're focusing only on one thing and we're not really paying attention to other subtle things that may say, this child is a child of abuse. This is not a one-time injury. And then, although we're probably moving away from this, I hope we are, making educated guesses, as we say, about projectile mechanisms. This is an exit wound and an entrance room, and it went up or went down. That is something that we are charged to no longer do, because we know there's so many different alterations these days that can actually be a problem if we make guesses about things that we have no training and expertise to make. So let's go a little bit into what I call applied forensic as it relates to the emergency department and go through a few things, making it a little bit more clinical. All right. So one of the things I wanted to make sure that persons know, we have a problem here, and I don't know medical students, UWI, a lot of times we don't pay attention to how we actually classify our wounds. And any cut at all, anything that looks like a wound that is open is called a laceration, but that's not so. So we classify wounds forensically, and this is how we should do it all the time. So either according to the mechanisms, either blunt or sharp, and here the object sharply divides the skin and underlying structures, all tissues are evenly cut. Blunt trauma, on the other hand, tends to tear tissues, okay? And it does so by its weight or its force of impact. What a lot of us actually call lacerations are really incised wounds, and it's an example of sharp trauma. So the sharp edge of the weapon is drawn across the skin. The wound is longer in the skin than it is deep. Sharply delineated wound edges, no bridging. I'll show you what bridging is in a little while. And forensically, more than one incised wound on your patient should cause you to suspect self-inflicted injury. Now, it doesn't mean that somebody can take a knife and cut you all up, but think of it. Is it possible that this is self-inflicted injury, especially if they're very shallow incised wounds? So this is a contrast. So if you look here, this is the laceration. It's blunt trauma, and blunt trauma has torn this gentleman's scalp here. And if you notice right across here, looks like a nerve coming across here. Okay, the edges here this is bridging, by the way, and the edges are very irregular. All right, very irregular. So it's deep, but it's very irregular. This is a laceration. This is blunt trauma. And then you have here, you notice that edges here are nice and what you might call clean. There are no bridging. So this is your incised wound, or a cut, a true cut. Now, it is possible it is possible for a sharp instrument to cause blunt trauma, depends on the force. Okay, so it's not, oh, well, you see, you have to be careful. You can have a sharp instrument causing blunt trauma if the force is high enough. Other types of sharp force trauma: stab wound. We know we have puncture wounds, and they're typically caused by pointed objects. Now, of course, for puncture wounds and stab wounds, one of the things that we have to be mindful of is that the wound trap may be deeper than the alleged length of the wound, of the weapon. And therefore, we have to be very careful. And most of us in emergency room, with stab wounds to the belly, for example, we treat very, very carefully, all right, even though it may look superficial. On the blunt force trauma comes a lot of things that we know. This, the abrasions, and these abrasions may be impact abrasions, pretty much because they may take the shape of the object. Contusions, or lame and bruise, fractures, laceration, tears, avulsions, and human bite marks tend to come under blunt force trauma. So this is an example of a contusion. Here you see this discoloration right here, and this usually results from leakage of the capillaries under the skin. And remember that sometimes this may take a while to come up in a patient. Now, human bite marks are particularly interesting. It's the most useful of patterned injury to aid in identifying a suspect. So says the literature, okay? And you usually recognize a human bite wound because it has what we call two arches, an upper and a lower arch, right? And it may be partial. Sometimes it may be associated contusions and even lacerations if the force is enough to break the skin. And sometimes you just have some contusions associated with that. So here you see this oval shape wound here. You can easily recognize that this may be due to some teeth. You have an upper arch and a lower arch. There's some contusion, and there is a little laceration right here. Okay, so this would be an example of your bite marks. Now, particularly with bite marks, forensically, you want to photograph the wound. I like to photograph lots of things, but for bite marks, it's good to photograph the wound. And especially if you don't have a forensic odontologist who can come and make a mold of your bite mark, then you may have to assist by just taking a photograph, documenting the size and location. But swab the wound before you clean it, because remember, bite has DNA, saliva associated with it, so it's something you want to swab. So don't just take a picture. It's a good thing to just swab and send it off to the lab, because that might be the one thing that may link that bite to the alleged perpetrator. Okay. Now, always preserve bite mark evidence as much as possible. Be precise and follow the appropriate protocol if you have one. If you don't have one, try to get one. If you do have a forensic odontologist, well, we don't have one, but if you do, then please use them. And don't touch the bite marks prior to gloving. And that's a principle, right? Don't go touching your evidence with your bare hands. So you have patterned injuries, and again, this could be very useful forensically because the object that is used to inflict the wound leaves a pattern, and that could be used to tie in a patient to tie the wound and to the patient's the mechanism. So the object bruising wound leaves an imprint. It may be seen with blunt and sharp force trauma, and what I like to tell people, don't try to describe to determine the pattern. Just describe accurately what you see, but make sure it's a pattern injury, but describe it. Better yet, take a photograph. I do that, and it helps sometimes in trying to prevent a lot of description that maybe you don't have the right words to use. So this is an example of a patterned wound here. Okay, it's well outlined here. Okay, And sometimes people will call this pattern a train track kind of pattern. You see these patterns here. In this case, this gentleman is a 16-year-old boy who was beaten by his father with a belt. All right. So you can see outline, very distinct outlines of an object that was used to inflict this wound. A slap can also do the same thing. So if it's enough to break a few capillaries, then you might see that, of course, you may have difficulty in detecting this injury in someone of darker skin. And oftentimes this injury doesn't last very long. So you may see it or you may not see it. This is an example of a patterned wound as well. It's well circumscribed here, okay? And it has a shape to it. It has a specific shape. Now, this particular shape could be anything, but it's all you would say. It's a particular well circumscribed shape, right? Don't go calling it a cigarette burn, for example, unless you are sure that this is what it is, or there's a history to support that this is what it is. So let's talk a little bit about abuse characteristics as we talk about practicing clinical forensic medicine. The first thing I like to say is that the injury itself is not proof of abuse, and that's important for us because we want to protect, especially when we have kids and the elderly, we want to protect them. We see an injury, but we have to be careful. We don't label everything as abuse unless we have a few bits and pieces of information. So there's a distinction between an accidental and an inflicted injury. Accidental happens by chance, inflicted is very intentional, caused by another person, okay? So indications of an inflicted injury in general, they're unexplained or are inconsistent with the caretaker's information. Very, very important when you're thinking forensically, because remember, you have to interpret your findings for the court. Does it match what the person is telling you? Bilateral injuries tend to be inflicted injuries. Accidental injuries usually are on one side of the body. So you're seeing bilateral injuries, have a little bit of high dose of suspicion. Clustered injuries, injuries that are in one place or injuries that are hidden. So body injuries, especially in children, persons are careful to hide the abuse. So, so you might not see them on the arms. They're only on a particular area, or they're in a particular area like the buttocks, okay? That is cause for some concern. And of course, patterned injuries are very rarely due to accidents. It can happen because I accidentally did cause myself to have an injury with my iron. Very patterned, very outlined. Nobody did anything to me. And I had to explain it to my colleagues. Well, you have this thing, who burned you there, right? But so the point is, yes, pattern injuries are more likely to be associated with inflicted injury. But again, listen to the history and make sure there's not an alternative explanation. Other things, grab marks on the upper extremities, right? You have grab marks. You can't accidentally grab yourself. Not accidentally, okay? Human bites. We've never heard of a human bite that was accidental. If you think about it, I would have to intentionally try to bite you or bite you, okay? So human bites are not considered accidental bites. Injuries that are consistently noticed after the patient goes to a particular residence. So every weekend they come home, there's some injury. You have to start thinking, is this an inflicted injury? Internal injuries, we know, and delay in seeking medical attention. And this is seen usually in three sorts of patient groups: the young, the elderly, and those persons who are either mentally or physically disabled and they are being abused. Then there will be a delay in when they're brought to you, whether it's in the emergency room or in your private office. Fractures that are more than one fracture in various stages of healing, that's a red flag. Multiple or repeated fractures to the same bone or the same area, red flag. Injuries accidentally discovered during an exam. So for example, a child is brought into you for ear pain or belly pain or something, and you just happen to notice the injury, it was not reported, that's a red flag again, especially if you're dealing with those special groups that I just described. Posterior rib fractures are most likely due to inflicted injury. It's really hard to, especially in a child, right? But even so, in the back, right? Think red flag, rib fractures and a hole in a child. You have to be very, very cautious that this is not, in fact, an abuse situation. Again, if you look at burns, any delay in obtaining treatment rather, cigar or cigarette burns, more likely to be inflicted, but again, they could be accidental, okay? And yes, I think I'm a walking pathology specimen because I was accidentally burned on my thigh. My grandfather, he was smoking and I walked by and I got a burn on my thigh, and I knew for sure that my grandfather burned me. He loved me dearly and I loved him back. Immersion burns, a sock like, that what you call glove and stocking type of pattern, that is an inflicted injury, more than likely, because you understand that whereas I might step into the bathtub with one leg and it's too hot and I burn myself, I don't step in with two legs at the same time. Somebody would have to have lifted me and put me in that bathtub. So that bilateral injuries again, think about that. Burn patterns corresponding to heated objects, I just said that, right? Or the burn is sharply outlined. That again, you have to be concerned that this is an inflicted injury. Scalding things, usually children who burn themselves, certainly the ones that we see, they're pulling something off the table, the kitchen table, or they throw over a cup or something, so there's a splash. So you have a very ill-defined kind of pattern to your burn. Well circumscribed, things with outlines strongly suggest that this is an inflicted injury. Bruises in areas not usually visible, black eyes that are bilateral or with no injury to the nose. You got to be concerned that this is inflicted injury. Again, both eyes, I don't know how much doorknobs you can walk into at the same time. So you have to be concerned when you see both eyes, okay? Pattern bruises we spoke about, and multiple bruises in various stages of healing. Those are red flags for you to consider that, this has some forensic value to it. So we remember that with respect to this aspect, that we're saying that the injury itself is not proof of abuse, but we should have a high index of suspicion when we're dealing with our populations, when they come in with injuries. And based on some of the things we just said, consider, is this accidental? And if it's accidental, it really doesn't have much of a forensic value, but certainly if it's inflicted, then we know we are going to have a little bit of extra care in this case. So if you look at some guiding principles as we talk about interpreting and examining our patients, the medical examination, remember earlier we had said that the crime scene is really our patients, but this crime scene has rights, okay? So your crime scene can say, no, I don't want this, and no, I don't want that, and no, you will not take pictures of me, and no, you will not pass that speculum on me because I don't want it. So while we recognize that this may be a matter for the court, so there may be legal implications, you have to respect the right of your patient in this case, right? When we're looking at collection of evidence in a clinical space, ideally that the collection should be standardized, and that helps. It should follow sound forensic principles, and for each aspect that we're doing there, its own set of principles, for example. We want to avoid contamination of our samples or contaminating the particular area, all right? We want to make sure that when we, for example, we are dealing with a wound and we want to photograph the wound, we want to photograph the wound first before we touch it and clean it. That's very, very important. We heard about bites. Don't go cleaning it off and then taking a swab. That would make any sense, because you would have removed and or contaminated your sample. And avoid alteration of your samples. And you can do that by simply doing things to them that you ought not to do. So if you see something, you want to collect it, if, for example, let us say a leaf, you want to collect it in that state, as much of it, that state as you see it as possible. All right. You want to make sure that when you collect something, you don't change it. You have persons who would collect, let us say, a condom, and you want to do things to it, and then you want to package it nicely, you want to clean it up. That is not what you want to do. Collect it as you see it and package it according to the particular guidelines that is set out by your lab, your local lab. And when it comes to preparing a medical report for legal purposes, because at the end of the day, this is what clinical forensic medicine is all about. I like to say, at the end of the day, this is what it is, okay? The information that you present must relate to the case. And other times we have some inappropriate, irrelevant information being sent in a report. And that is important because sometimes that information could actually be prejudicial. Accuracy is vital, okay? Right is right and left is left. Hand is this thing here with your fingers on it. It is not the whole of your limb. That's important. And when we do these reports, sometimes I read a doctor's notes and they say things like, there is a laceration on the eyebrow. Well, which eyebrow? Is it in the eyebrow itself? Is it above the eyebrow, etc.? You need to be very, very accurate. And as much as possible, avoid medical jargon. Ecchymosis is probably not something you want to write in a medical report, because the courts can't tell you what an ecchymosis is, all right? The report you send is not your case notes. It is you're not going to send your notes and say, okay, judge and jury, you sort it out. You are to write it in a very specific way, in a formal reported speech way, and make sure as you do so, you use terms that can be easily understood, leaving no doubt as to what you meant by what you are writing. And if we're testifying in court, I just put that in there because, as I said, it may very well reach there if you're practicing your clinical forensic medicine. Prepare beforehand. And of course, it's a whole, Dr. Alfredo Walker, if he's in here, will tell you, has a whole course on how to do this. But just some general things, prepare beforehand. Don't walk in there as if you think you can remember everything and walk with your notes. You have to prepare the case. Why am I being called? What aspect of this might they ask me on? Kind of like if you're preparing for an exam, and be early, okay? You don't want to hold up the court. You need to respect the court and its officers. Though by the time you're practicing your clinical forensic medicine, you would be doctors. You go in there and you have more knowledge medically than perhaps you do than the court. Your job isn't to tell him that you are the it of medicine. You are to respect them, respect that they're professionals, and you must behave in such a manner. The only reason you're there is to help them, to either help the accused or the complainant. Documentation. This is where I think most doctors fall down in our forensic duties. We want it to be detailed, but we must be aware it must not be too lengthy. Should be comprehensive, and that could either be a narrative, it could include diagrams and photographs, and these are all part of your documentation. Accurate. So wounds must be measured. You notice in my photographs you had measuring scales. There's no, well, it was an approximately 1 centimeter by 1.5 centimeter. Measure it, and measuring isn't hard. A simple ruler will do. You don't require any specific thing, okay? You must write legibly. Remember, I said earlier, this was something that was considered a big forensic mistake. You must be legible if you're going to write. If you're going to type, then you must make sure that it's grammatically correct. If the courts cannot understand your writing, it is of no value to them. And you may find yourself in court just to read your work. And that makes no sense. You want simple language. You're not telling the people that they're simple, but you want language that they can understand. All of us have language. The courts have their language and so on. But if our notes and our interpretations and our reports are going to be used by persons who do not understand our language, then we have to make sure that we translate our language. Ecchymosis and so on, some things you just can't avoid. I always say there's no layman's term for posterior fourchette. You just got to write posterior fourchette, okay? But there are other layman's terms for other things. And if they are, use them. Perhaps don't say the word contusion, use bruise, okay? Describe what is seen and refrain from opinions. When I give tests to my students and doctors and say, okay, tell me what this thing is, I give you pictures. Everybody is willing and ready to jump to conclusion. Oh, this is a belt mark and this is a cigarette burn. We have to be careful about that. Describe what you see, call it a pattern injury, leave it alone, whatever the pattern, whatever, contusion, whatever it is, and leave that alone, all right? Use terminology accurately and consistently. Don't write one thing up there and then in the body you write another term for it, because sometimes you may use different terms, but don't use the word incised wound and cut interchangeably. Don't do that. Make it consistent throughout. If you have diagrams, include your diagrams because they aid in persons, instead of trying to say, it's 2 centimeters distal to the antecubital fossa. That might be a little bit problematic. Better to show them where it is. And photographs, are they essential? It depends on where you are. I like photographs, but it may not be practical. I think it would be essential for forensics, but it may not be practical only because where you operate may not have either a state provided or institution provided camera for the use solely for forensic purposes. So that might be a little bit problematic. And we try to avoid persons using their personal cell phones to take pictures, okay? But consider that I believe they are indeed essential. So final thoughts then, the physician and nurse is the forensic examiner. So those of you are aspiring in medicine, you're aspiring to all the different aspects of forensics. When you become a doctor and you work in certain places, you're seeing someone with a stab wound, for example, you are a forensic examiner in that, even though you may not have a certificate that says so. Detection and preservation of evidence is key. Procedure should be protocol driven. And know if there's a protocol that should guide you. A lot of times it is there and people don't know about it, or people think it's there and it's not there. And though we have spoken about forensic science, and it was clinical forensic medicine, oftentimes the two will coalesce and form a partnership. They go together, right? Think, for example, a sexual assault case, the science and DNA analysis that's going to be done in your forensics lab to look at all the science behind that of the material you collected will go together with your examination findings to help the courts decide on the outtake training in principles of forensic medicine. We haven't gone through all the different nitty-gritties of it, but it's something that you should do. And really and truly, I want you to remember that clinical forensic medicine really would not be clinical forensic medicine if it did not involve the court. So when you think about what you're doing with a gunshot wound, a stab victim, a motor vehicle crash victim, etc., you need to remember that you may actually have to be involved or participate in a court interaction. Learn what is required of you. And then when you've done that, do that which is required of you. And when in doubt, ask someone. Call Dr. Alfredo Walker. He will assist you. Ladies and gentlemen, thank you so very much for your time and attention. Okay.
Thank you very much, Dr. Hutson. We would now like to have our question and answer segment. If anyone has any questions, you can either turn on your mic and your cameras and ask your question or add it to the chat.
Dr. Walker. Am I allowed to answer Dr. Walker, Madam Chair?
Yes, you are.
Okay. Dr. Walker. Oh, who is that? Yes, Dr. Walker, you're being devil's advocate. Let me stop sharing. Okay. So Dr. Walker is saying, why does UWI not yet have a postgraduate course in clinical forensic medicine? Dr. Walker, I can't really answer why they don't. Okay. And I know that's a loaded question, right? And you're taking darts at me, Doc. I hear you. You're setting me up. But I don't know. And truthfully, perhaps because those persons who can lead the charge for that has not led the charge. Does that help? Does that satisfy you, Dr. Walker?
Good afternoon, Dr. Hutson. Thank you very much for that. And no, it doesn't satisfy me because this has been my bonnet for the longest while.
Yes, I know.
The clinical forensic medicine is non-existent in the standard MBBS curriculum and in the MD curriculum in North America as well, and in the United Kingdom. The Caribbean situation is more acute, more unique in that, unlike the United Kingdom, where there are clinical forensic medicine practitioners, it's a recognized subspecialty with recognized training, recognized oversight body, the Faculty of Forensic and Legal Medicine. That doesn't exist in the Caribbean. And you have A&E officers, most times it's the junior officers, the house officers, the registrars, who don't have a clue and don't have your level of qualifications, training, and expertise to handle these cases when they come to light. So as such, UE should at least consider having a 6-month certificate course in the first instance, basically expanding on all that you have covered in this 1-hour lecture. And for the life of me, I can't understand why it hasn't yet happened, although I have been advocating for years.
Yes.
We have district medical officers throughout all the Caribbean islands who function as clinical medicine doctors. They even get involved in assessment of dead bodies on scenes and certification of death. And they have no training. And it's a big gap. And who suffers? The population.
Okay. So
the criminal. So I challenge you, Dr. Hutson.
You have been challenging me, yes. I have accepted the challenge, and there are lots of things that I'm working on, and that is the truth. So I have not relegated it to the past, and I do agree with you actually. But also to say, certainly at UE Mona, medical students do get a little tips of clinical forensic medicine. They do have a module on sexual assault management. So, and that's part of our clinical forensic medicine. So it's not entirely zero. We would like it to be more, but certainly we do have that. It's a 5-hour workshop they get when they come to emergency medicine. So there is hope, yes. So they do get something, all right? Thank you very much, Dr. Walker. I hear you. You see, you have to do this to me in a public space. Terrible. Okay.
So second question from me. If an institution and many institutions in the Caribbean do not have a policy for one, the procurement, and two, the storage of photographs of injuries, be it physical injuries or injuries of a sexual assault nature. What is your advice to the accident and emergency personnel who will be assessing them in terms of storing? You know, we know that procuring these images on personal devices is a no-no. So, you know, you need to get buy-in from hospitals to have a dedicated camera in the accident and emergency. What do you all do in Jamaica?
Okay, so right now we don't have such a policy, and a lot of it depends on who is doing the evaluation. So at my institution, I have a camera that I have dedicated, my own personal money, and I say, okay, use this camera for such purposes. And you could do that. Now, in this day of nobody buys a camera, a lot of persons do actually use their cell phones. And we have had discussions with our DPP, the office, and allow them to guide. In other words, will they accept that and so on? And then we look at what do you do with them? So what I normally would say, if a photograph is taken with your cell phone, it should be downloaded and usually consultant on, or if it's a sexual assault case, it comes to me. So I will be the storer and custodian of those images, and it's downloaded onto a computer that I use in my office. It doesn't go anywhere else. And you know, these days nobody puts anything on discs, but in the days I would put it on a disc, and you keep that. But you have a discussion with the police. I've had a discussion with the police for that, and one of the things is that really and truly they can't give us a camera. And so we are pushing that. So you continue to push that. But in the meantime, you know, because really and truly photographs are hugely useful adjuncts to forensic evaluation. And if it is that you can have doctors who understand what they're doing and say, when you send it, delete it, then, you know, it's not the best thing to do at this time, while you can, but it is something while you continue to push, right? As I said, here, I have a camera that I say use, and it stays in the emergency department. So although it's a personal camera, I don't use it for anything else except that. All right.
If you have a shrewd defense attorney,
Yes.
An image that is downloaded, stored elsewhere, that is not on the original device, there could be allegations of manipulation.
Yes.
So doctors need to know, one, that if they're using their personal devices could actually become an exhibit in the case, and, you know, all the pornographic sites that they have visited, etc., all of that information can be interrogated.
Yes.
And a downloaded image without the original image can easily be thrown out as being manipulated.
Right.
So the hospitals have to procure a dedicated camera like you have, and they also need to have a dedicated place to store the images and store the original memory cards which they were procured, else it's useless.
Yes, and I agree with you. And again, that is why sometimes it's good to just discuss things with other persons outside, especially the courts. Allow them to say, okay, this is the best. And at the end of the day, I say it's up to the judge to determine whether or not he or she will allow a particular piece of evidence in the court. So the sort of next best thing is just to take it, have it, and then allow the courts to you know, have some sort of semblance of protocol or some semblance of proper storage, and allow the courts to help to design, to determine that it's the next best until we get to that stage. And hopefully, because Jamaica is actually just has formulated a national protocol for sexual assault cases, and that's one of the things that I raised, that we need to have a camera that is provided by the state or the institution. It must be mandated, and so on and so on. And then we can talk about custody of it and so on. So hopefully, I know it was actually placed in it, and we'll see when everything comes to fruition. Let us hope that that is also something that they will fulfill.
Yeah. Okay.
Okay.
So thanks. Yeah. The last is just a comment. I'm actually putting together a training package for DMOs in the Caribbean. I already started putting a list of topics together, and I've gotten feedback from a DMO in Antigua and one in Trinidad and Tobago. So rest assured, you will have a role to play in the execution of its content. Thank you.
Okay, Dr. Arthur, you had a question. I see your hand up. All right. See, Dr. Alfredo just dominated everything.
Hi, Dr. Hutson.
Hi, dear.
So it was kind of, my hand is up because it's falling out from Dr. Walker with regards to the photographs. So as you know, I'm an emergency physician, but as you also know, the only campus that does the sexual assault teaching, evidence collection teaching, is Mona. Fight as I might, Cave Hill is like, no, we don't do it, full stop. Being an emergency physician, I found myself thrust now into the role of police medical officer. So it basically fell on my doorstep, even though it was something that I liked before, it fell on my doorstep. And the police here, they also don't take photographs. I've asked for forensics to be present if I'm doing a sexual assault kit. They said no. So my question is, if there's no protocol, then what do you do? That's one. And two, even in taking photographs, they need to be taken a very particular way. Yeah. So is there training for that for your residents or for your medical students to say, well, it's not just selfie, it's not just, you know, you have to take it at a particular angle with your grayscale ruler, et cetera, et cetera. Okay. So those are my two questions.
So the question is, if there's no protocol that's specific to any protocol at all, or just to photographs?
Any at all. Well, we don't have any at all. So
okay.
Right, I am trying to do now is I am trying to create a protocol for Barbados, because each police medical officer does it differently when a sexual assault is presented to them based on jurisdiction. So I'm trying to standardize that. And of course, there's none at the hospital because their thing is we don't do it. Okay.
Well, in a way, you've answered the question. What to do if there's no protocol? Well, you make your own. And I don't mean it that simply, but you have to lead. If you see a need, then you start the ball rolling. And this is what happened to me at the University Hospital several years ago. When there was no protocol, I was told, oh, yes, there's a protocol, Dr. Hutson. I said, can I see it? Well, I'm still waiting to get it. And every time so I developed my own, and I would say my own, I developed a protocol, and over the years we have tweaked it. And then when I was properly certified, I just, and you know, you tweak it and you reform it and you change it. And so you involve all these different persons. So what you're doing, Dr. Arthur, is what you should do. You lead, gather I spoke to the forensics lab, I spoke to the police, I spoke to the DPP's office. I said, tell me what you want, tell me what it is, and I came up with a protocol that primarily was used at the University Hospital of the West Indies for years, and it's actually still being used now. But everyone knew that there was a protocol now at the University Hospital, and I disseminated the protocol, and they would follow the protocol, right? And because I had a buy-in from the DPP's office and the forensics lab, that was something that was there. So in the absence of a protocol, develop one. Do your research, develop a protocol, allow it to ask persons they get backative from key stakeholders, and run with it, because it really, especially if you have sexual assault matters, you really shouldn't be doing things just ad hoc, right? And there are resources all about. There are resources everywhere that you can use and modify. I do not recommend just carte blanche taking a protocol developed for somebody for use in the United States or Australia or Canada to just say, okay, this is what you should do. But there are elements of it that are universal. Take that, tweak it for your local environment, and allow it to be. After a while, persons, you're going to get the attention of people, and you're going to get persons to come on board with you. It's going to take some time, but it can work. Dr. Walk, there was the other question, Dr. Arthur. There were two parts. That is
that was with regards to the photographs. The other question was regarding.
Right, the one with regard to the photographs, specifically whether there's training. So I don't do medical students, which is in terms of training specifically for photographs, or we do it for the residents, right? And back in the day when we did a lot of cases of sexual assault, I actually had a room that was set up specifically in a manner and recommendations for taking photographs. But again, it's not hard. There's, like I tell people, you don't want to say you have to have a forensic scale. You can take things, there are principles that you can follow that can be simple, that are actually easy to implement. But a lot of things just take a little bit of initiative and buy-in from persons, All right. Thank you. Dr. Walker? Yes.
Yeah, this is a comment in response to Dr. Arthur's plight in Barbados. So yes, you have to take the bull by the horn, and somebody has to lead from the front.
Yep.
The easiest thing to do is for you as the lead in clinical forensic medicine / sexual assault to call a stakeholder meeting with the police, the investigators, the crime scene, the DPP's office, your department, and basically sensitize everybody to the problem that there's a disconnect. There needs to be a standardized protocol that all stakeholders contribute to and have buy-in. As Dr. Hutson says, you cannot, one, import somebody else's protocol, or two, develop a protocol and say, you have to do this. It has to be stakeholder engagement, making them aware of what the issues are and the implications if things are not done a certain way. Come up with a protocol that everybody feels that they contributed to, so they feel a certain level of ownership, get sign off on it, and implement it. That's the only way things will change. You need the equivalent of, a criminal justice oversight committee in each jurisdiction, so that all the stakeholders could come up with a protocol to how to deal with living patients of physical and sexual violence and, fatal assault cases. So you have to run with it, just like Dr. Hutson created her niche area in Jamaica. And of course, there's still room to expand. You can start the ball rolling in Barbados, because if you get buy-in from the higher ups in the police force, the crime scene people simply cannot say, no, we don't do it. It's not our job. Once it's filtered down, they would have no cause to. If I can give you an example, the lone properly trained forensic pathologist trained in the US went back home to St. Lucia to practice. And there, the crime scene people would come to the postmortem, take photographs, but not give her a copy of the photographs, which we all get to review to help us finalize our reports, saying that it is their property. Well, guess what? because of my involvement together with the, the director of the Forensic Science Laboratory, that practice has changed. It is good. It is okay not to know. It is not okay not to know what you don't know. And when you know better, do better.
Mhm.
So this is your challenge, Dr. Arthur.
Yeah.
Run with it.
Yes, I certainly agree with that. And you're going to get pushed back, and it's going to be hard work, but you have to, you're going to get pushed back. I tell students all the time, a lot of fights over the years, I've taken my fight all the way to the Assistant Commissioner of Police. I'm not afraid of the fight, and he would just say somebody's going to put me in jail or slash my tires. But if you deem it important enough, and I think so, and maybe I'm biased in saying so because of my own interest, then you run with it, push back. Everybody, the doctors didn't want to do it. What are you telling me? I don't have to do this, and it's going to take so long. And well,
Yeah.
So it is. You take 2 hours on a gunshot victim, the whole department descends upon him. So you descend upon the sexual assault survivor and do what you have to do. So, right now, things are way better in lots of ways. I don't get as many complaints again. PP's office or the forensics lab. I used to get a ton. So, it's going to take time. And I've been doing this for 20-something years. So don't worry, you have a long ways to go.
Thank you. Thank you, guys.
All right. There was another question, I think. Justice Lachu. Dr. Hutson, how does a doctor become a certified sexual assault forensic examiner? Okay, so you can do that by training a formal course, and there's several courses that are put on elsewhere. So for example, when I first did this, there was nobody in Jamaica telling me about sexual assault management. So I had to go elsewhere. So I did mine with the University of California. It was a 2-part course over a 6-month period. So it was a didactic part, 40 hours, lots of assignments and so on and so forth. And then I did the pediatric section. I had to go away again for that. Now, I recognize that I don't think that it is absolutely necessary for one to be certified as such. Because if you look at the programs in the United States, for example, the emergency medicine residency program, incorporated in the program are sexual assault examinations and so on. And at the end, you don't get a certificate that says you're certified, but it's part of the training. I think what's important for us is the training. I had to be trained because there was nobody here to train me. So you're coming back and you're training the doctors and so on. And as long as it is ongoing, which we do, we have seminars, you come and you learn, and then you have oversight. That's important. I provide oversight for the doctors. So every time they do an examination, if I'm not physically there, I review the notes and I provide that oversight. That is training, okay? And so it just depends on where you are. And certainly, Justice Lachu in Trinidad, I always tell him that, you have quite a number of trained persons there. And they should have their certificates to say that they have done quite a bit, 1 week long of training. I don't know where they are, they've disappeared, but you do have, but the point is you can do it overseas for now. And when we have our clinical forensic medicine certificate course, that will be part of that. Okay. I've totally taken over the young ladies thing. All right. Was there any other questions? I'm not seeing any other question. Okay. Oh, Justice Lachu, you're saying that, yes, there are many people doing many different things, but sometimes the parts never merge into a whole. And you know what, Justice Lachu, that is true. It was true here of Jamaica. But one of the things that you have, what you need. And as I tell, I did the training in St. Vincent and I was very happy. What you need is someone. So in Barbados, that someone is going to be Dr. Arthur. You need that one or two people, but you just need one person to take hold of this thing and say, I am going to run with it. I am going to take on the fight. I'm going to insist that we follow protocol and so on. And then after a while, it takes a while, but after a while, it will come together. I think what happens, especially with sexual assault management, nobody wants to do it. No doctor wants to do it. They don't want to go to court. They don't want to do this thing because it takes too long. And so they shy away from it and they do something. So they end up doing something. They end up doing, what they think they should do, what they heard, rather than say, I really need to do this thing properly. But because I believe you need to have one person who is going to say, it's not just about what I do at Mount Hope or what I do in another hospital. It's not about what I did here at UHWI. I made sure that it was being done everywhere else and quarreling with all my colleagues and making sure we come together. So I think that's what is going to happen. It doesn't need legislation for that. It just needs somebody to run with it.
Okay.
A lot of energy, a lot of fight, a lot of mouth, and strong tires.
Could I ask one more question? With respect to the assessment of sexual assault victims, the UK has set up dedicated sexual assault referral centers, SARCs, which are basically standalone accident and emergency departments purely to deal with sexual assault victims, removed from the normal accident and emergency /ER. Does that exist at the UWHI? And two, how do you all treat with the level of privacy, confidentiality, and discretion that is needed to do a sexual assault examination in a busy accident and emergency department? Okay,
so that's a two-part question. The lawyers will tell you must answer two-part questions, sir. But anyway, so the first part was, does such a facility exist? Well, in Kingston, the closest we would have to that is SOCO, the Center for the Investigation of Sexual Offenses and Child Abuse. So it's a combined, it's a police investigative part combined under the same roof with the clinical part. So they have doctors who staff that. So essentially, most cases that come into Kingston would usually go to that center. The spillover, we get what I call the spillover. And sometimes the doctor is not available for whatever reason. They may have gone on leave or something has happened. So we get the spillover. Or if patients are unstable, they come to us first. So we have an agreement that if they come to us and we determine if they stay with us, then we call the police and we will do it. Now, do we have a private room? Yes. So it's not, unfortunately, at this time, a dedicated room, but we do have a room that we could put them in, totally private, and we can set things up. And that's what we do. So we do have a private space that we could do this in, far away from prying eyes.
Okay, good. Yeah, thanks. There's Dr. Salim Vacharia online, who is from San Fernando General Hospital, accident and emergency consultant. I'm just interested in how they treat with their sexual assault victims at San Fernando. Sorry for putting you on the spot, Salim.
Sure, and good afternoon, everyone. Thanks, Dr. Hutson, for that presentation. So as I mentioned, we don't have a separate entity as such. We have one general emergency department, say about the adults and pediatrics, but there's a certain section isolated from the general flow of patients that we go to that particular area and to treat with patients in a private manner to ensure that confidentiality. So there's some semblance of maintaining confidentiality at the discretion of away from the hustle and bustle of the busy emergency department. And as mentioned before, the same challenges that Dr. Arthur would have faced, Dr. Hutson would have expressed, I'm sure is not unique to only those 3 territories and probably more widespread and probably in some instances even worse off. But we still have to, as you mentioned, push and agitate to get this going. And it's just a matter of time that it will come to fruition. So just to keep on agitating, going fit, and hopefully it will come to fruition during our lifetime, hopefully. Yeah, just for sure.
I quite agree with that. And it takes time, but they say what nothing good is going to happen in a short time. It takes a lot of persons, and you're not a one-man show. As much as I will shout loud and fight, it is not about me. I can't do it alone because the standards are not my standards, and you have to involve the core. I love the DPP's office. I call them with everything. They knew my name before they knew me, because I seek, and when we have protocols, I say, tell me, is this okay? What else would you like to see? The lab and so on. So we were tweaking things, and in that protocol space. So it's going to work. But while we, I don't want the students here to think that clinical forensic medicine is all about sexual assault, right? There are lots of other things, and I think we focus a lot on sexual assault because it is a big deal, and really is awful. But just to make sure that they understand that simply evaluating someone who has been stabbed will require some good forensic principles being assigned, and photographs there as well. And these are things that you need to take care of. And I often lament the absence of photographs for seemingly simple things like our gunshot wounds and so on. The doctors here will know when it's a sexual assault case. Yes, they take the pictures, but oftentimes they don't do it for these, interpersonal violence cases, or even when you have the motor vehicle crash and the person's coming. It's always, sometimes they forget that, and it's important. And the detail. You have to remember. For me, I think forensics always think the court. The court is going to go to court. It's going to go to court. So you want to be careful, you want to be detailed and accurate about what you document. It's not just, cut on forehead, man took a knife. And there are lots of other things you need to make sure that you pay attention to. Okay. Yes, the workplace accident, absolutely. So it's when I saw the thing about the care of a police officer for clinical forensic medicine, I smile. It's like, okay, I would not have thought so, but really and truly, I guess the police officer can represent the court, right? He represents the legal system, law enforcement, and therefore you're caring for him. You're practicing forensic medicine, so it could be anything really. And the way to think of it, will this end up in court? All right.
Thank you very much. We would now like to implement back activity so that the audience could share some real feedback on the session. So some said it was enlightening, concise, informative. So I would now like to hand you back to the chair to the level.
So I hope you all had a wonderful and learning experience. At this time, the feedback form link has been sent, and we would like you to take a minute to fulfill it out. It will be greatly appreciated for documentation and for improvement to our future events. As we leave, I would like to leave you with these words. Eleanor Roosevelt once said, "The future belongs to those who believe in the beauty of their dreams." Firstly, I'd like to thank our featured speaker, Dr. Rhonda Hutson, who despite a busy schedule graced us in this evening with an amazing and enlightening presentation where we were all extremely grateful to learn about clinical forensic medicine. First, we are most happy that you were able to give us an insight to the behind the scenes of the field of clinical forensic medicine. We are hopeful that your audience was able to take notes and was reminded, if not educated, on the importance of clinical forensic medicine. We would also like to extend our gratitude to Dr. Alfredo Walker, our advisory board member, for joining us with your presence this evening. We appreciate your endless support and thank you for playing a key role in supporting us throughout our journey thus far. We thank you all for taking your valuable time, effort, and consideration in investment in literacy and properly establish the future of pathology. It is not only an act of success, but one of greatness, showing us the paths that you have all walked. I would also like to recognize Dr. Anthony Collins, Dr. Salima Varachia, Dr. Latonia Otter, and Dr. Katie Lachu for attending our session. Last but not least, ladies and gentlemen, I would like to thank you all for accompanying us tonight and making our event a success. And we look forward to your continued support. To all of our UE students and staff across 3 campuses at the University of Ottawa and Eastern Ontario Laboratory Regional Association, and especially to our specially invited guests, thank you, thank you, thank you. Next CPALMSI session featuring Dr. Nox Yadak, who will deliver a 45-minute talk on transplant pathology, will be held on the 12th of January, 2023. Ladies and gentlemen, this marks the end of our session this evening. Thank you all for joining us for this, our 20th installment of CPALMSI. We hope to see you at our future events. Good evening, all.
Good evening. Thank you very much.
Good evening. Thank you, Dr. Hutson. And just before everyone leaves, I just want to remind the audience of the upcoming 6th Caribbean Medical Legal and Forensic Symposium, which is taking place in Trinidad and Tobago at the Hilton Hotel this coming Friday and Saturday. I have reached out to the executive of the Pathology Club for a list of 10 names of Pathology Club members for to receive complimentary registration for the event. I just got an email a while ago with 4 names in it. There is bandwidth for 6 more names. So if you are interested, kindly reach out to Ranjiva Bridgelal and Anne-Marie Minghon. I can accommodate up to 10 people for complimentary registration. It's going to be big, it's going to be huge. I just shared the program in the chat with everyone. So looking forward to seeing some of you all there and advocating for the future.